want to thank Project HealthNet Echo and Parsa Trust for being our partners in delivering these programs in Pakistan. The topic of my talk today is redefining the natural history and outcomes of Hep C in the DAA era. And before I move forward, I do not have any disclosures related to the current talk, although my research has been funded by various governmental and non-governmental organizations over the years. And what I will do today in the next 20 to 25 minutes or so is tell you a story about hepatitis C as it has evolved and progressed in the last 10 to 20 years or so, but particularly focusing on the last 5 to 7 years when DAAs or directly acting antiviral agents became more common and have been used across the globe. I will do this through the lens of archives, which stands for Electronically Retrieved Cohort of Hep C Infected Veterans, which is one of the world's largest database of Hep C infected persons and uninfected controls. It was created by myself and my team as a part of my Career Development Award nearly 20 years ago, and we will talk about its creation and the impact it has had on Hep C knowledge generation over the years. And through that lens, we will talk about how does Hep C progress in terms of liver fibrosis, and do direct acting antiviral agents affect survival when given to patients with Hep C. And also talk about the effect of DAAs on extrahepatic complications, because that is becoming more and more important nowadays. We will finish it off with some post-marketing safety and surveillance data that we've gathered together. And this also will highlight the importance of databases like archives in answering key clinical questions that you may face in your daily practice. But let me set up the stage by sharing a patient consultation with you. This is a typical patient who might walk into your office or your clinic. And this is a person who is newly diagnosed with hepatitis C and has had all the workup already done. Now, when this person comes to see you, he or she would have many questions about his or her disease. These questions would include, do I need treatment? What are the treatment options? And if there are more than one, which one is the best option for me? What are my chances of improvement? And even more importantly, can this disease be cured? What are the benefits and harms of this treatment if I elect to take that? And what are the consequences if I elect not to get treated? Now, as a clinician, you also have read every single clinical trial related to Hep C, but for this particular question, you're also thinking at the same time, is the treatment that I'm going to prescribe to this person safe and effective in the real world setting? You know all about clinical trials, but how do they translate into the real world settings? Is that treatment going to be cost effective and equally importantly, cost beneficial for this patient? And what will be the societal impact of treating this patient? Or for whatever reason, if the patient does not get treated, how does that impact the population as a whole? So when I started off my career about 20 years or so ago as a junior faculty, and I was trying to seek out a subject area to work on, I came across Hep C, and it was of great interest to me. I started asking a few basic questions to understand the current status of knowledge in Hep C. And at that time, many questions that we take for granted nowadays were quite unanswered. For example, we did not even know how many people were eligible for treatment for Hep C in the US and globally for that matter. How many people initiated treatment? How many people completed a full course of treatment? In those days, the treatment options were very, very limited. The natural history was not as well described as we know now. There were hardly any treatments, as I mentioned. So the effect of treatment was relatively unknown at a larger scale. The consequences of Hep C were just being figured out, and very little was known about effect of hepatitis C beyond the liver. So my initial goal was to define treatment cascade and clinical outcomes in persons infected with hepatitis C, and I started thinking about how would I be able to answer these questions. I would need a very large database at a national scale with large number of patients and long-term follow-up to be able to answer that. That is where I came across or started working with the Veterans Affairs healthcare system in the US, which is the equivalent of military hospitals and combined military hospitals, CMHs in Pakistan, India, Bangladesh, etc. These are military veterans who have now retired, and they seek most of the healthcare through the system. In the US, there are about 22 million veterans, of which 9 million are enrolled in this healthcare system. And in any given year, about 6 million are active care seekers in any one of the 150 tertiary care hospitals or 820 plus community-based outpatient centers. The good thing about this system is that everything is linked with a single electronic medical record system. And these data were being downloaded onto different servers across the country. For example, clinical diagnoses and utilization were downloaded onto one database, pharmacy information was available in another, labs in yet another database, and so forth. So we identified Hep C infected people and joined all these databases to create a unified database, which we called archives. Nowadays, it is much more easier because we have a corporate data warehouse, which does most of that work for us, but it took us many, many years to create and clean that database. And this is what we have in terms of numbers. So we started off with the 120,000 plus Hep C infected persons back in 2002, 2003. In the first iteration, we did not have controls, but then we added Hep C infected controls to be able to do natural history studies and clinical outcome studies. And in the most recent iteration, we have close to 400,000 patients with longitudinal data over a period of 20 plus years, and same number of Hep C uninfected controls, which are matched based on demographics. Now, what has been Archive's contribution to Hep C knowledge? We asked and answered several questions related to Hep C, which I mentioned previously were unanswered. These included who initiates and completes treatment, who should be treated first, is the treatment safe, tolerable, and effective in the real world setting? Does adherence in the real world setting make much of a difference in the DAA era? We found out and quantified liver disease progression rates with and without treatment. We also looked at who was treating Hep C and how that shifted over the years when more and more treatments became available. And we also looked at extrahepatic manifestations of Hep C and the effect of treatment on those outcomes. In terms of impact, we have had 39 high-impact publications so far, which have been published in several high-impact journals and have been used by many of my mentees across the US to work on. So the first question that we asked was, who initiates treatment? And nowadays we know this relatively well, but remember in those days, no data were available about this fact. So in the pre-DAA era, when we only had regular standard interferon and ribavirin, we found out that only 11.8% of Hep C infected people were ever initiated on treatment. Now, we repeated this study in the DAA era about 2 or 3 years ago, and with the DAA treatment, this number has gone up dramatically. When we published this study, about 50% of people were being initiated on treatment, but now the number has gone up even further. The number is in between 60 and 70% of all diagnosed patients are being treated for Hep C now. And you can see this, we always had more patients being diagnosed each year than being initiated on treatment. And this trend reversed in about 2014 when the number of people being treated started exceeding and far exceeding those who were being diagnosed every year. Now, the next obvious question was how many people complete a full course of treatment? And in the pre-DAA era, when we only had interferon and ribavirin, one of the more important factors were experience of the provider in treating Hep C. So we looked at centers or hospitals where more than 200 people were being treated by a group of providers. And 200 seemed to be the cutoff number. If the number of patients being seen in that practice or hospital were less than 200, the treatment completion rate was about 20% or so. But if the number exceeded 200 for any given hospital, the number doubled to about close to 40% or so. Now, in the DAA era, this number has gone up dramatically, and now about 90% of the patients complete a full course of treatment. And this is very important in terms of health policy, as well as in trying to understand and achieve the WHO goals of a hepatitis-free world. Because we need to bring people into care and start them in treatment to be able to cure hepatitis C and eradicate it from the world. Now, the next question that we wanted to ask and answered was, are DA regimens effective in the real world? We had looked at that question in the pre-DA era, but since we're talking more about the current era, we looked at several regimens and in several different settings. We looked at people who were treatment naive and patients who were treatment experienced, those with cirrhosis and those without cirrhosis. With the newer treatment, interferon-free regimens, it turned out that almost any regimen that you pick and almost any setting or set of patients that you look at, the treatment SVR rates were about 95 to 100% or so. So in other words, even in the real world, most people were getting, achieving sustained virologic response, which is equated to cure. Now, one of the issues that we had in the pre-DAA or the interferon era was there was a big mismatch between what we saw in clinical trials in terms of attainment of SVR versus what we saw in the real world. So in clinical trials, the SVR rates were close to 40% with interferon and ribavirin, but in the real world, only 13% of people achieved SVR. With pegylated interferon and ribavirin, this difference was 54% in clinical trials, but only 30% or so in the real world. But with the new DAAs, which are all oral regimens, we have demonstrated in several studies that the rate of attaining or achieving SVR is almost identical in clinical trials and in the real world, which is about 95% or so. So this is a great achievement that we have we have attained in the last few years or so. And I think this is also an important segue or a good segue to Dr. Arora's talk later on as to how this can be translated into community, towards community doctors. We looked at the safety of DA regimens, and we demonstrated that, for example, hematologic toxicity of the newer DA regimens, even those that used interferon, like boceprevir and telaprevir containing regimen, was very, very low. So less than 4% of patients treated with DA-based regimens had grade 3 or 4 hematologic toxicity. So now we had kind of created a picture of cascade of care for hepatitis C in the DAA era, that most patients are getting into care, they are being started on treatment, they are completing a course of treatment, they are attaining SVR in very high numbers, and they have very low rates of toxicity. So another question that we asked was about the natural history of Hep C from the time of actual infection. Now, previously, the most challenging aspect of determining natural history of Hep C had been ascertaining the time of Hep C infection. We always estimated based on risk factors when the patient may have gotten Hep C. But because we had a cohort of more than 250,000 patients and controls on which we had longitudinal data, we found a very large number of people who had an initial negative hepatitis C antibody and a subsequent positive hepatitis C antibody. So in these patients, we could determine with relative accuracy when these patients actually seroconverted. And then we created the first seroconversion cohort of close to 2,000 Hep C infected patients and same number of uninfected controls and followed them for a period of 9 years or so. And by the way, this was a retrospective follow-up. So by the end of 9 years, 18% of Hep C infected people had developed cirrhosis, but only 6% of uninfected people had developed cirrhosis. One important thing to note is how quickly cirrhosis developed in these two groups, particularly rising sharply in the Hep C infected people. So within 2 years of infection, 6%, and within 3 years of infection, 10% of those people have already developed cirrhosis. Among those who have cirrhosis, within the first 3 to 4 years or so, 7 to 8% would go on to have an end-stage liver disease event, or what we call a hepatic decompensation event. And by the end of year 9, almost 10% of Hep C infected people with cirrhosis have developed a hepatic decompensation event. Time to cirrhosis was significantly shorter in those with Hep C, which was quite understandable. And similarly, time to first hepatic decompensation event was also much shorter in those with Hep C. Again, that was quite intuitive. Now, we updated this cohort only last month, and we're still working on this manuscript. Now we have a much larger number. We have 12,881 patients whom we have a seroconversion date. And we have followed them for a period of, again, about 9 years or so in a retrospective manner because we have longitudinal data. And in this group, what we have found is that, first of all, in this study, we are comparing seroconverters who were treated and attained SVR versus those who were not treated for Hep C. So by the end of year 9, 17% of those who were untreated, but only 14%, less than 14% of those who were treated and attained SVR had developed cirrhosis. The mortality difference is quite stark, 30% versus 3.5% by the end of year 9. Hepatic decompensation events were relatively uncommon, but still a major difference between those who were treated and at SVR versus who were untreated. Hepatocellular carcinoma, on the other hand, is extremely rare. We only found a few cases, a handful of cases of hepatocellular carcinoma in the 12 or 13,000 patients that were followed up for about 9 years or so. Now, does treatment improve overall survival? And we first showed a survival benefit more than 12 years ago using interferon-based regimens. And we showed that no matter, even if when the patients did not complete a full course of treatment, there was a survival benefit compared with those who were untreated. So in other words, there was some inherent effect of interferon and ribavirin, regardless of virologic control, that was improving their survival rates. We replicated the study or redid the study in the DAA era, and we looked at people with cirrhosis, without cirrhosis, and various regimens over a period of time. And again, we saw that compared to those who were not treated and who had cirrhosis, those were the ones who had the worst survival. And any treatment with any of the DAA regimens, whether the patient was cirrhotic or non-cirrhotic, led to a significant improvement in overall survival. This was also replicated by another group from California, who looked at people who attained SVR versus who did not attain SVR, and found that SVR was associated with a significantly improved survival. Now, that was overall survival. What had not been studied till very recently was, do the DAAs actually make a difference on viral hepatitis associated liver-related mortality? And we published this study about a year ago in Journal of Hepatology, again looking at tens of thousands of patients over a long period of time and ascertaining their cause of death from the CDC's National Death Index database. And it turns out that those who were treated had a significantly improved survival compared to those who were untreated. The survival difference was about 5-fold. When you looked at those who attained SVR versus who did not attain SVR, those who had SVR or those who eliminated the virus had a 13-fold improvement in survival overall. And when you look at regimen, it turns out that those who were treated with the DAA regimens had a much better survival compared to those who were treated with older PEG, interferon, and ribavirin-based treatment. Now, another thing that I think would be very interesting to Dr. Sanjeev Arora and his talk later on is that who is treating hepatitis C? So when we look at the interferon era, the largest proportion of patients was being treated by gastroenterologists and hepatologists, shown in the blue bar out here on the extreme left. Over the years, the proportion being treated by gastroenterologists and liver specialists has dropped significantly, and the number of patients being treated by non-physician providers like physician assistants, clinical nurse practitioners, etc., has gone up dramatically. All other types of providers have remained relatively stable in terms of proportion, but this is very important in what Dr. Arora calls democratization of Hep C treatment, meaning everyone can treat hepatitis C given the basic knowledge and training of medicine. And others have shown that clinical outcomes and virological success rates in patients who are treated by non-physician providers are similar to those treated by any other group. So let's move on quickly to what happens beyond the liver, and we'll talk about three things quickly. First of all, we showed that Hep C was associated with an independent risk of cardiovascular disease events. Hep C increased the risk of CVD events by about 27% or so, even after adjusting for traditional risk factors. Now, does treatment make a difference? And we published this study in Gastroenterology about a year or so ago. It turns out that those who are treated have a dramatically reduced risk of future cardiovascular events, and the reduction is by about 1/3 or so. Those who are treated with the DA regimen have the most profound benefit. All the patients treated with older PEG-RIBA regimens also see significant benefit. SVR, on the other hand, while does have a benefit, but is not as dramatic as the type of treatment that you use, in other words, DA regimens. So here it seems that the regimen is more important in reducing cardiovascular disease events than merely attaining SVR. But when you look at diabetes and the effect of DA treatment on diabetes, the incidence of diabetes is also significantly reduced in patients who were treated. But here, SVR seems to be more important than the regimen being used. So whether you use PEG-RIBA or the new DA regimens, your improvement or benefit was similar, but achieving SVR had much more benefit than not achieving SVR. So in short, or in summary, treatment with DA regimens dramatically reduces the risk of cardiovascular disease events as well as incident diabetes after successful treatment. Let's finish off with a couple of post-marketing observations. And those of you who treat Hep C would remember that there was a lot of hype about 2 or 3 different possible side effects of DA regimens. One of them was, do DAs worsen renal function? And we looked at serial GFR values in a large number of treated patients over a period of time and found that, yes, while DA regimens are associated with a decline in eGFR, this did not lead to any decrease in virologic response rates or any other poor outcomes. So what we concluded from this was that while renal function does decline with DA regimens, clinical significance of this is quite uncertain, and this should not be a reason for withholding treatment in these patients. You may also remember that there was a big hype or scare about increasing the risk of hepatitis B reactivation in patients treated with DA regimen. And we did one of the earlier studies on this, and now this has been done by several groups across the globe, that actually turns out that HBV reactivation is a relatively rare event, and the risk associated with DAA regimens is comparable to those treated with PEG-RIBA regimens. So in other words, DAAs do not increase the risk of hepatitis B reactivation significantly, and again, this should not be a reason for withholding treatment in these in the co-infected people. Finally, there was a report a few years ago that DAs were associated with an increase in the risk of hepatocellular carcinoma, and the people differentiated between recurrence of HCC versus de novo development of HCC. Again, we looked at that and published this a couple of years ago, and again has been replicated by other groups that DAs do not increase the risk of HCC. In fact, there is a signal towards an improvement or a reduction in the risk of HCC, which is independent of attaining SVR. So again, HCC is not associated with DA use. In fact, DAs may be useful in reducing the risk of hepatocellular carcinoma. Finally, an interesting observation, a couple of interesting observations regarding statin use and fibrosis progression. And we found this very interesting observation, which we first saw in one of the randomized clinical trials of DA agents, that those patients who are on statins had a slightly better SVR compared to those who are not on statins. So we looked at that in a very large real-world cohort, which was archives, and found that was indeed true. And we also found that when we follow these patients' liver fibrosis using FIB-4 score, statins are associated with a significantly reduced fibrosis progression over a period of time. Statins were also associated with a reduction in the incidence of hepatocellular carcinoma over a period of 8 to 10 years or so. We still do not know the explanation for this, probably just some anti-inflammatory effect or some other immunomodulatory effect, or maybe inherent anti-cancer activity of statins that we are still trying to find out. We also incidentally found that proton pump inhibitors, PPIs, are associated with a dose-dependent risk of progression of liver disease to cirrhosis and to hepatic decompensation and hepatocellular carcinoma. We found, on the other hand, that tricyclic antidepressants were associated with a reduction in risk of cirrhosis and delayed time to development of cirrhosis, but this was not associated with a decreased incidence of hepatocellular carcinoma. So what are the lessons that we learned in the DA era from archives and more recent natural history studies? Well, first of all, it is very clear, and I think there is unanimous consensus now that newer DA regimens are as effective in the real world as they are in clinical trials. Now, what we added onto this as the benefit of treatment is apparent within first 12 to 18 months of treatment. Therefore, deferring treatment is not really a good idea in patients with Hep C. Complications of Hep C also appear quite frequently, both hepatic as well as extrahepatic complications. And when you look at a patient population as a whole, the number adds up to a lot of people developing these complications. And if you treat them early, you prevent these complications, again leading us to the conclusion that deferring treatment is not really a good idea and not a good option. Difficult to treat populations are not difficult to treat anymore. I did not show the data, but we've done several studies in patients with advanced renal disease, chronic kidney disease, patients with cirrhosis, patients who are treatment experienced, and so on and so forth. Others have done studies on HIV co-infected people. And almost every population that we look at, SVR rates and benefits of treatment are similar to the non-affected population. And we've also shown you, hopefully I've convinced you that benefits go way beyond the liver. Therefore, again, coming to the conclusion that deferring treatment is not a good option and everyone should be treated early and treated aggressively. Now, to finish off this, just want to show this new paradigm. So on your left is a slide that I showed at grand rounds I gave about 10 years ago at Yale Medical School in New Haven. And at that time, we had recently demonstrated that if you take 100 hypothetical Hep C infected people, in the real world, only about 1 to 2 people will actually get true benefit of whatever armamentarium that we had. In other words, only about 2 people would go on to achieve or attain virologic response and any benefits associated with that. Because most of the people were not being treated, and when they were being treated, were not completing treatment and not attaining SVR. This is a lecture that I gave, a dean's lecture at Cornell about a year or so ago. And now the paradigm has shifted dramatically. If we take the same 100 theoretical patients, now we can expect SVR attainment at least 32. And I would argue this number is more close to 40 or 50 now. People will actually be cured of hepatitis C even after all the barriers that we have at this point in time. So we have come a long way in terms of Hep C treatment and reaping the benefits of treatment. And I think this treatment should be offered widely and to everyone who is otherwise eligible. And these days, there are very few contraindications to treatment. I will stop here. I think I took maybe 22 minutes or so. I would be happy to answer any questions. Back to you, Dawood and Asad.